while the session is ongoing, we should keep our speakers on mute. Then when we have questions or contributions to make, we'll be giving time to do that at the end of both sessions. So please permit me to quickly introduce our keynote speaker, Dr. Godswill Ogbonnaya. He is a public health physician at Federal Medical Center, Umuahia, and has professional interest in healthcare quality, patient safety, and clinical epidemiology. He's also very passionate about improving health outcomes for patients using evidence-based strategies. Dr. Godswill Ogbonnaya is a fellow of the West African College of Physicians. He's also a fellow of the International Society for Quality in Healthcare. He has a Master of Applied Science in Patient Safety and Healthcare Quality from Johns Hopkins University and a Diploma in Infection Prevention and Control. Dr. Ogbonnaya also holds a Master of Public Health from the University of Lagos, Nigeria, and is a certified professional in healthcare quality. He is the former head of departments, community medicine, FMC Umuahia, and a senior lecturer at Gregory University College of Medicine, Umuahia. You can see that he's the best person to take us through infection prevention and control as a tool to improving healthcare quality. Please make welcome Dr. Godswill Ogbonnaya.
Thank you so much, Dr. John, for that introduction. Am I going to share my screen?
Do you want to share? You want us to do from our end?
You have the access to share it.
I can share.
Yes.
Okay. Okay, I can share my screen. Can you see my screen?
Yes, we can. Yes, we can. Dr. Ogbonnaya, is it me or your slides are not moving? Have you started your presentation? Hello, Dr. Godswill.
Have we lost him? Have we lost him?
Yes, it's no longer on the call.
So we take the first presentation while we sort him out. The second one, I mean, or you call him. I guess it's internet. Internet access is very bad. Amaka, you may have to call him. You are the manager here. You don't just sit down, please. Call him and ask what's going on. Thank you.
I'm on it. All right, ma'am. Thank you.
So while we are waiting for Dr. Ogbonnaya, okay, let me see.
Because
I have a
it's
message.
being recorded, we need to resolve this. It's either it's on, we take the second presentation, quickly solve it.
Okay. Mrs. Mbang,
I'm here.
okay, would you like to take your presentation now while we get Dr. Ogbonnaya sorted out?
No problem.
Okay. So Mrs. Mbang will be sharing with us her facility experience and how she's been able to use infection prevention and control to improve healthcare service delivery in her setting. So please, I think Alina already has your slides, or do you want to share
Yes.
from your own end?
No, should be shared from there.
Okay.
Okay, he's back.
He's back.
The doctor is back.
Okay.
Okay.
Back.
Okay. I'm sorry, I don't know what happened. I got locked out. I've been trying to connect since then. I'm so sorry for that.
It's okay.
Internet problem.
It's okay.
Okay,
It's okay.
let me go
Thank
through
you.
the presentation. So right away, that's the outline. And I'll start this presentation with this quote from the Institute of Medicine because of internet instability. So this landmark
I think Dr. Ogbonnaya has network issues. So while I try to reach out to him, please, Mrs. Mbang, can you continue?
All right, my slides are out there.
Okay, Alina, thank you.
Good afternoon, everyone, once again. My facility-based experience is from the primary healthcare center here in Anantara, in Calabar South local government area in Cross River State. I'm a nurse midwife and an IPC practitioner. Next slide, please. Okay, that's the signpost to the health facility. And you can see the staff, the community health extension workers, and the lab technologists. This was during the 5th of May, the World Hand Hygiene Day, that I took out a day with them and we had to demonstrate hand hygiene at the facility. That's the front view of the facility. You'd see it also posted across River State Development Primary Healthcare Agency. Basically managed by a lot of agencies, AQs, basic healthcare funds, and so on. Next slide, please. Now, going to getting into the background, I actually live directly opposite, my residential address is directly opposite the primary healthcare center. And with my idea of being a community development officer, I've had an interest in this particular facility right from when I moved in 2014. I personally provided a borehole water to them when they didn't have a good borehole, and also made sure that NEPA came in and gave them electricity, at least for work to be convenient at night. So the primary health, the background is that the primary health care center has a bed occupancy of 12 beds, a delivery suite, a laboratory, and a pharmacy unit. Services conducted includes gynecological and obstetrical services, immunization, HIV counseling, testing and treatments, reproductive health, DOTS clinic, RDTs. You have diagnosing, treatment of non-communicable ailments, and referrals. That's by FIND, which of one of the agencies. The source of water now is electrically operated borehole. The waste disposal is an open dump pit. Next slide, please. So based on the above information given above, few days after my deployment to the facility in October 2022 by the Basic Healthcare Provisions Fund as a mentor midwife, residential, I readily seized the opportunity as an IPC enthusiast to identify the gaps in IPC at the facility and improved on them. One of them was during routine immunization, which is usually done throughout the week, but specifically on Thursdays. I observed that the RI provider would neither wash the hands before, after the health talk, or during the immunization from child to child. So that prompted my information about the basic thing like hand hygiene. I also became bothered about the delivery suits. It was not well kept, so I got somebody out here to pull down the curtains. We washed, we reorganized the center. So if you walk in here today, it's a very beautiful place, netted, and a lot of things actually have been put in place. So in December 2022, I was nominated for the state's training of trainers on integrated service delivery across the 18 local government areas in the states, which actually involved workers from the primary healthcare centers, which further strengthened my involvement in supportive supervision, not only in the domicile facility, but across 5 other LGs. Within the South-South, we have, looking at Cross River State, we have the 3 senatorial districts, the South-South, the Central, and then the North. So I'm basically here in the South-South. So we have about 5 facilities within the ward where I work. So I always take out time, sometimes I interact with the staff during their ward meetings, heads of units meeting, they call it. So sometimes we meet there and then we interact, and our focus basically is on infection prevention control and other ways to see that things are done well. So my vision was to collaborate with other multidisciplinary. Like I said, we have a very good laboratory outfit here. The only thing is that they're not carrying out gene experts, which tests, which they take to the infectious disease hospital. But other testings and so on are being done here. So I decided to collaborate with them. And then the pharmacy technician is also here. You have the dietitian who comes in for the babies who have nutritional problems, so that we could curb the prevailing rates of healthcare associated infections. Most times, the procedures are not properly done. Sometimes the words are being used. So these were areas I was very skeptical about, and I decided to look at them. So the action I took was to, with the support of the primary healthcare coordinator, they have just one in this particular Calabar South local government area. It has 12 wards and a lot of either primary health centers or health posts within. So I collaborated with her for this Calabar South LG, and we conducted a one-day refresher training on globally accepted IPC practices for the healthcare workers, and on a different day with mothers. This particular different day fell on the period when we had cholera outbreak. So I took out time to talk to mothers who came in for antenatal clinic and mothers who came in for immunization on best practices on hand hygiene, even when they have their babies, how to clean their hands before breastfeeding and after breastfeeding. Please, next slide. I've been on my vision. Yes. So the next slide now. Next slide, the pictures, okay? So training session, you can see the pictures here. I actually use a manually developed flip charts. And these are students from the College of Health Technology who usually stop over for clinical practice and experience. So I had to write out the 5 moments of hand hygiene, like you can see displayed there on pieces of papers, and kept them on the trolley of the patients, because my observation was that they have a lot of signages in the facility, but people don't identify those signages. Either they just pick those signages and then post on the wall and off they go. So I had to bring this to their notice, write them down and explain to them. The 5 moments are pasted after what I did here. And I posted, you can see a client lying on the bedside that is posted by each bedside, so that immediately they spot it, they are aware. And actually they know that this is what they're supposed to do. It's not been easy, because these things are usually like, it's a small facility, it's business as usual. But I think with what I did here, there's a lot of improvement. Today was our routine immunization, and I watched and observed the RI healthcare provider giving immunization, and she had her alcohol-based hand rub on that table. So per every child, she makes sure that she has a good hand rub before taking the next child. This was not applicable within the facility when I joined them initially. Next slide, please. So the water, sanitation, and hygiene had been another concern. The ward, the units, I don't know when they were building it, the built environment, there were no zinc within the lying-in wards. Where I'm sitting down here is a lying-in ward. There was no zinc attached or shank for hand washing. But where the staff is standing there is just by the entrance to the facility. So these are information that, and it has a signage on that bucket. The moment anybody walks in there, a staff just sits there and says, please wash your hand. So as you're moving out of the facility, somebody says, have you remembered to wash your hand? So that's very significant for us at the door. Then at the rooms, in front of the rooms where those shanks were not built, we decided to provide Veronica buckets and then posters on the wall, believing that with time, the agencies and then the community will look into these things so that the plumbing repairs and placement of these buckets will be done. Currently, we have placed these Veronica buckets by the entrance to these rooms while waiting for the adjustments to be done. Next slide, please. So the water that the next slide that we have here, the next slide that we have here is the waste dump site, which I frowned at seriously when I came and saw the place. And I discovered that most of the dump, the waste, not the safety boxes. The safety boxes are always carted away by the environmental officer. So that one at least is taken away from the facility. But other waste segregation is done well. At least I've inspected their segregation. But when it comes to the dump sites, like you can be seen behind this overhead tank, it's an open pit and it's not accepted. But at the moment, we're looking at the Ward Development Committee, because we meet here once every second week of every Tuesday. And the Ward Development Committee has the clan head. The clan is made of about 8 villages within. So we have these meetings and we've been talking to them to see how they can also come in to see how they can give us a befitting pit to put this, our dump as it's here. Next slide, please. So recently, in December, I was invited by the state IPC pillar in respect of the IPC training of the 196 wards and about 303 healthcare workers in the state across the 18 LGAs, including secondary and tertiary facilities. And I appreciated the effort for inviting me, because I was a very useful instrument to pilot this program in the States. This was by NDDC and WHO with participants drawn from across the above areas with focus on primary healthcare workers from 15th of April to 19th of April 2024 in 5 clusters. You can see the Yako cluster on your left with some of us. I'm there seated with a yellow and black gown. That was my cluster in Yako, where we had to train the people closer to their area of their workplace. Then there in the middle of that picture, you can see the state IPC team with focal persons across the 18 LGs. We had this program to train the focal persons. Tell them, actually, IPC is not the usual jamboree of going for meeting upon meetings upon meetings and maybe looking for entertainment and snacks. It's a more serious business. As I speak, we have a platform for the LGA IPC persons. We also have a platform for the team. So we've conducted a monitoring and evaluation in this team, we did twice. We've just done the first one around the 5th of June, and we've expected to take the second one on the 30th. So we're not toying with IPC, and I believe you that as far as I'm in that team, that I'm not going to allow this program to just come like maybe any other program and just fizzle out like that. So in my conclusion, IPC has become an integral part of primary healthcare facilities, and with the necessary resources, improvement of healthcare at the grassroots level will be a guarantee. I want to really appreciate the organizers for giving me this opportunity. I love IPC so much, and I believe that being in the state IPC team, it will be a different story for Cross River State. Thank you. Last slide. Thank you very much. Thank you.
Thank you so much. Thank you so much, Mrs. Mbang. And that was a wonderful presentation. Your passion and love for IPC comes across. If you've been able to do this just in 2 years of getting there, you have really achieved a lot. Please, can we give our reactions? Show her love. Applause.
Thank you very much, Ma. Thank you for being my facilitator.
Well.
Thank you, Doc. Thank you. That was fantastic.
Thank you.
That was really fantastic.
Well, I want to make a suggestion.
Yes.
I don't know whether you have access to the WHO hand hygiene audit tool. So you should have documented the baseline and then do it again so that you can do a publication. Maybe you should look into that.
All right, ma. Thank you. I would also look into it. Like I told you, we're just kickstarting in the States. So there are a lot of things that we're trying to put on ground. I'll look into it, ma.
Okay.
It's a good advice. Thank you.
Fantastic. You are doing very well. Just keep it up.
Thank you, ma. Thank you.
So I don't know, Dr. Ogbonnaya has still been going on and off. He's on 1 minute, he's off. Okay, somebody has a hand up. Tony Ediga, please, can we hear your thoughts? Can you unmute and speak?
Yeah, good afternoon, everyone.
Good afternoon.
This is a wonderful practical facility experience that most of us in IPC look forward to seeing. We are trying to establish IPC across supported facility. You are there, over there in your state supported facility. We are doing some stuff like this in CDC supported state as well. But again, I actually want to ask, do you have a team that you work with? Because these beautiful things you are doing, usually IPC, the way we are trying to build capacity now, we want to make sure that it lives beyond us. You have the passion, and we have said it several times to people. IPC is about the passion that you have. It's not a side hustle. We don't want to take IPC as a side hustle anymore. We want to make sure that in whatever facility where we're implementing, we have people who work with us who have similar passion, so that by the time you are no longer going to be there, whatever you put in place will continue to outlive you, and that standard will be set, and then your facility will continue to be a center of excellence in IPC. I don't know if you have a team. No, it's a small facility.
I do. As I speak with you now, we have a focal person for this facility. And that's a woman, the person who is in charge of routine immunization. So while I sat with her this afternoon, immediately she brought out her geostyle and other things. I asked her, what about your sanitizer? Two, I have a sanitarian in my team, in our team. I actually worked about 25 years of my career as an IPC nurse. Maybe I was just roaming around until I attended the program in Lagos. I have a sanitarian who had worked with me in Teaching Hospital Calabar. So I actually recommended that he should be in that IPC team with us. So he is one of the state IPC team members. And within the LGA, the local government where I am, we have actually picked some young women who have about 15 years or more to practice, so that whatever we're inculcating in them as focal persons, they will be able to move on. That's why we kept on saying during the training program that it's not a jamboree, because most of them didn't have Android phones. They said they were just using, and they've been attending several workshops. They never had an Android phone. So we don't made it that mandatory. I remember the last day of the training in my cluster, somebody had to go and buy an Android phone to take the post test. She couldn't even access the phone and other things, but it's an information. So we're moving towards that line. It's not going to be lost. As far as I'm strong, because that's always what we ask for. The younger persons, I actually pick nurses who are young in the profession, and across the 18 LGs, we have across that 18 LGs about 13 who are nurses. So the 13 who are nurses are the focal persons. Then we could pick maybe one other professional like a CHU or who as an assistant, but the 13 are actually nurses and they are functioning. Those who are not functioning, we had to drop them. So those who were upcoming, those who could pick text messages, we had to ask them to showcase their practical presentations, especially after the training. So they sent in their videos, sent in their pictures, and those that didn't, I kept on sending messages with the IPC pillar. So that is the way we are. It's not going to just fizzle out like that. I don't think about that way.
Fantastic. We love this. Thank you so much.
Thank you.
Also,
Thank
we
you.
want your facility management to be in full support. And one of the other things we also advocate is that going forward, IPC should have it should be a line item on the budget for the facility, so that you have a budget, so that each time you require anything, your hands sanitizer, whatever it is that you require, is already budgeted for. Your facility is supporting. If you need to have meetings, they come around to support. So when there is interest from the facility management, all of this will move on smoothly without any challenge. Thank you, and over.
Thank you very much, sir. I really appreciate your interest, and I'm telling you that the agencies are not leaving the facilities fallow. As I speak, we have alcohol-based hand rub over 5 jars that are not being used. The supplies here and so on had been constant, but notwithstanding, when they sent in their capacitation or something, they always pull out some money for us to work with. So the WDC, I forgot to say, I'm very sorry, the Ward Development Committee, like I said, is made up of the clan head and other members of the community. We are using them to help us to work with the traditional bed attendants, because there were a lot of things too I saw. A traditional bed attendant takes delivery with bare hands, no glove. And when asked, did you screen the patient for any serological infection? He said, no, we don't screen, nothing will happen to us. So this is how far we've at least penetrated beyond just the facility into the terrain where you have the traditional bed attendants and healers, bone healers and so on. So it's gone beyond the facility. Thank you.
Thank you so much once more, Mrs. Mbang.
Thank you, ma'am.
So can we have Dr. Ogbonnaya? Would it be easier for Alina to share your slides so that you can reduce the demand on your network? Dr. Ogbonnaya, if you can hear me, please respond.
Ogbonnaya, are you not in here? What's going on? Network?
His mic is muted. I think he needs to unmute.
Yes, I can hear you. I had to switch to another network. I saw a call came into the phone. That's why I went off temporarily. Can you hear me now?
We can hear you now. Do we ask Alina to project your slides?
It's okay. I can still share from here. It makes it easier for me to flow rather than saying skip the slide.
So you have the floor now, sir.
Thank you so much. Sometimes this thing can really, attempt to destabilize somebody. Okay. So I was talking about this landmark publication by the Institute of Medicine in 2001 that said that between the healthcare that we have and the healthcare that we could have lies not just a gap, but a chasm. So the report identified a significant gap between the quality of healthcare that is possible and the quality of healthcare that is actually delivered. Of course, this is based on the United States, but we know that it's applicable to every other country in the world, and it's particularly worse in the low and middle income countries. So the gap that they identified by this report, they refer to it as a quality chasm, which highlighted the need for improvements in the quality of care. And not only that, this huge gap leads to undesirable outcomes for patients, families, and healthcare providers within the healthcare system. Similarly, another physician, a pediatric nephrologist in the UK, also made this profound statement, which said that medicine used to be simple, ineffective, and relative. Dangerous. So this author identified that there have been significant progress and gains in medicine, in therapeutics and diagnostics, making it more effective. But then it has also become more risky. So if you look at the statement by Cyril Chandler, he's telling us, yeah, we are now more effective, but then we are also not very, very safe as we provide care. So if you marry these two, that takes me to the next slide that addresses the domains of healthcare quality, where you, from the IOM reports, and of course, WHO added the seventh one, you now have these domains of quality, where healthcare quality should be safe, should be effective, people-centered, timely, efficient, equitable, and integrated. So all working together define what quality is. So according to Chandler, we are more effective, but less safe, meaning that there's an urgent need for quality of care to be improved. Now, if I want to look through these domains using the lens of IPC, infection prevention and control, I can say that when you look at safety, IPC is critical in ensuring that patients, staff, and visitors are not harmed by preventable infections in the healthcare facility. In terms of effectiveness, we know that IPC is practical and evidence-based. And every intervention in IPC is based on scientific evidence. And what's the aim? To ensure that everyone within the healthcare environment benefits, that no one is harmed. Well, what of people-centeredness or patient-centeredness? IPC places the patients at the center of everything that we do. In terms of timeliness, of course, within the IPC, within the IPC family, we ensure that there is prompt response so as to prevent the spread of infections within a facility in the event of an outbreak. Efficiency, making sure that resources are properly used to address the needs of the patients. In IPC, we ensure that resources are not wasted in treating avoidable healthcare-associated infections. Why would a patient who was supposed to spend maybe 5 days post-surgery stay for 2 weeks or 3 weeks? That results in waste. So IPC ensures that there's efficient use of resources by protecting patients from acquiring infections. Of course, integrated, I will always say that IPC galvanizes the expertise of professionals from every discipline, from different disciplines, to work together towards making care safer. So you bring the surgeon, you bring the clinical microbiologist, you bring the public health physician, you bring those from the nursing services. So everyone comes together and provide integrated care for the patient. So I just highlighted this so that we can look at the domains of healthcare quality through the lens of IPC. We'll throw more light on that as we make progress. So I've mentioned, like I mentioned before, there's an urgent need to oh, sorry, that should be to close, not cross, please, typographic error, to close chasm through continuous improvement. And we believe that IPC can significantly contribute to bridging this quality chasm across all domains of quality, that is safety, patient-centeredness, effective, equitable, integrated, and so on. So, because healthcare-associated infections are the most frequent adverse event in healthcare, that's why IPC is central to any quality improvement effort in healthcare delivery systems. So, how do we define healthcare quality? Like, you see, it's a concept that sometimes is very difficult to define. But of course, when you see quality, you can recognize quality. But the truth is that quality is perceived, it's a perception. So it can differ based on one's point of view. So the quality of a service, the quality of a thing is the perceived value or goodness that someone sees in it. For instance, a patient might feel that a service is quality to him because he got well. And that patient may not really care how he felt after the treatment. But the fact that the hospital environment was very clean, or maybe the healthcare workers, they spoke to that patient nicely, they answered his questions, their bedside attitude was just top notch, that person say, wow, this place gives me the kind of quality I desire. On the other hand, a doctor might just be interested in, well, I give the patient treatment and the fever is gone. But the patient will not be happy because he was not treated well by the healthcare workers. So quality is a bit difficult to define because it can differ from different points of view. But then the WHO and some other organizations have galvanized this thought to put it in perspective by giving us this definition that you are seeing on the screen there. We say that quality of care is the degree to which health services for individuals and population increase the likelihood of a desired health outcome and are consistent with current professional knowledge. So quality is actually anything that will increase the likelihood of achieving the desired health outcome. And this desired health outcome from a patient perspective might just be that he wants to get well, he wants to feel better, he doesn't want to get harm while receiving care. And this must be based on the current professional knowledge, because what we may consider to be quality care today might become care that is actually less qualitative because of advance in knowledge and technology. The Agency for Healthcare Research and Quality defines quality healthcare as doing the right thing at the right time, in the right way, for the right person, and having the best possible outcomes. You can see that everything is gearing towards getting the best possible outcome. And that is where IPC really comes to mind, because healthcare-associated infection, like mentioned before, is the most frequent adverse event that happened to patients. So, and this affects the outcome. There is no surgeon that will want to operate on a patient and that patient will come down with a surgical site infection and that surgeon will be happy. Or maybe you are trying to insert the catheter, maybe a urinary catheter to a patient, and the next thing that patient is coming with a UTI that is related to the catheter inserted. No physician, no nurse, no healthcare provider will want that to happen. And of course, that has a way of affecting the patient. So our interest is always, let's get the best possible result for our patients. And it's good to also mention that high quality care does not imply the absence of harm. Obviously, that is true because we have seen the domains of quality from being safe to being effective, to being patient-centered, to being timely, efficient, equitable, integrated, you know. So there are different domains. So you could have highly effective care, but you could have some safety issues. Patient may still suffer harm. But the bottom line is high quality care does reduce harm done to provide to patients to the barest minimum. But it's also true that health system often fails to provide consistent, high quality care to all patients. That is why the subject of quality in healthcare is gaining momentum all over the world. Why is quality very, very important? Why should we talk about quality? Patient harm has been identified to be the 14th leading cause of global disease burden, and is comparable to diseases like tuberculosis and malaria. But if you are within the healthcare space in Nigeria, and in fact in low and middle countries, you will discover that there's a lot of investment, in a lot of investment towards controlling tuberculosis and malaria in the continent. I ask myself, why are we not seeing the same level of investment in quality of healthcare, in quality improvement in health? Maybe it's because those who are supposed to push for this are not doing their job, or the policymakers have not seen the need to push for quality improvement in healthcare. And that is why even in our country, we don't even have people who are specifically recruited to work in the field of quality improvement or IPC professionals. Most of the IPC professionals you see in our hospitals, they are just ad hoc staff. They do it as part-time. They have other duties they perform. We have not yet come to a point where we are having individuals who were solely recruited to IPC work or to serve as quality improvement officers within the healthcare environment. So it's very, very important for us to know that quality in healthcare matters, because it is the 14th leading cause of global disease burden. And studies have also shown the data projected is from the WHO, that 8.4 million deaths are attributable to poor quality care each year in low and middle-income countries. That is huge. 60% of deaths in low and middle-income countries from conditions requiring healthcare occur due to poor quality care. Inadequate quality of care imposing cost of $1.6 trillion each year in lost productivity in low and middle-income countries. Now, this is huge. So quality in healthcare is a subject that shouldn't be ignored. But for the purpose of this our conversation, we must know that infections in the healthcare setting is a huge problem. For us in this part of the world, we must start from preventing these infections. So what is quality improvement in healthcare? This is just one of the numerous definitions, but this one, I like this one. It says that it's a systematic and coordinated approach to solving problems using specific methods and tools with the aim of bringing about a measurable improvement within healthcare setting. So it's systematic, it's coordinated, it is aimed at solving specific quality issues. In this case, we have the huge problem of healthcare-associated infections. We don't want it to happen to our patients. So the aim of quality improvement is to increase patient and or staff safety, to reduce the cost of care, of course, to achieve better patient outcomes, experiences, and overall satisfaction, to reducing defects. Defects in this case refer to any clinical or operational event or a situation that happens in the setting that we don't want to happen again. For the purpose of this presentation, we don't want our patients to acquire any preventable infection while receiving care in the facility. Quality improvement can also address the issue of improving the work environment and ensuring regulatory compliance. From the previous conversation, in fact, the picture is already forming that there's a relationship between IPC and quality in healthcare. From the definition of IPC, we can see that the overarching objective of IPC is to use a practical and evidence-based approaches to preventing patients and healthcare workers from being harmed by avoidable infections. So that is the overarching objective of IPC, to prevent to prevent avoidable infections among patients and healthcare workers. IPC of course affects all aspects of healthcare, including how hospitals operate during and outside emergencies. It cuts across all departments, all disciplines. And defective IPC have been shown to cause harm and can lead to increased mortality among patients. Without effective IPC, it is impossible to achieve quality healthcare delivery, especially in our context. And in fact, globally, I was reading an article this morning, and in that article, I read that in the United States of America, that about the particular year, they recorded 110,000 deaths from medical failures. And out of these 110,000 deaths, 99,000 were attributable to healthcare-associated infection. So it's a problem everywhere. So without IPC, it's actually impossible to achieve quality healthcare delivery. What's the impact of HAIs on quality of care? I've mentioned before that HAIs are the most frequent adverse event in healthcare system. It constitutes a significant threat to quality healthcare. 10% of hospitalized patients develop HAIs in this part of the world. More than a third, more than 20% of surgery patients develop surgical site infection, still in this part of the world. And women and newborn, they are also at increased risk, up to 20 times when compared to their counterparts in the developed countries, of acquiring an infection while receiving care. HAIs can lead to preventable diseases, prolonged hospital stays, long-term disability, antimicrobial resistance, higher healthcare costs, and deaths. So HAIs impact quality of care in a very negative way. That is why IPC is extremely important. It is critical to improving quality of care, especially in our setting. Looking at the impact of HAI quality of care, looking at the Nigerian picture, the data you are seeing here is from a recent publication that was published, I think, sometime in either February or April this year, that says that healthcare infections are responsible for more than 93,000 excess mortality in the country, and has this cost attached to it, $4.5 billion per annum. So while I was reading that article, I saw two figures. I saw 4.5 billion and 4.5 million in the same article. I'm not too sure which one is the correct one. But whatever it is, the economic cost is huge. And the financial cost of treating the infection was estimated to be between to be about $600 million. That was in 2020. That was when they did the studies actually. So you will see that if we prevent healthcare-associated infections, then we will be, slowly improving the quality of care our patients receive. This is possibly the area where I will just go through the core components for IPC. I want to look at how they can support or play a role in quality improvements. The core components the WHO core component for IPC, they are really a foundation for establishing and strengthening IPC practices at the facility level, even at national level. And of course, if implemented, they are effective in preventing HAIs. It can also help to combat antimicrobial resistance, and of course, they can lead to improvement in quality of care overall. I see IPC, especially in Nigeria, I see IPC as the catalyst we need to push the frontier of quality improvement in healthcare. There are other aspects of healthcare that need improvement, but I think infection in the healthcare facility is a serious problem, and when tackled, can somehow rub off another aspect, and quality improvement in healthcare will become an issue that will be given due attention. So let's look at the core components. The first one is IPC programs. And if you look at IPC programs, when you have a robust IPC programs, it ensures that there's a dedicated team to implement IPC. That's the first point. So you see that you now have personnel, people who are committed to doing this work. That is one important aspect of quality improvement. You must have individuals who are skilled, who are knowledgeable, and who can implement the IPC. The IPC program, of course, we have clear set of objectives, measurable outcome indicators, and of course, targets for improvement. So when this is in place, you will now see that things will begin to work. And that's why we are having some, even in where we practice IPC, we still have this challenge because we don't have fully dedicated workers to do the work. They do it on ad hoc basis. By the time you know it, they are either transferred or moved to another unit. So we keep struggling with getting people to focus and do this work. And the effective IPC programs can also achieve, of course, it has been shown by studies, more than 30% reduction in HAIs. So once we establish an effective IPC program, it's almost guaranteed that 30% of HAI will be curtailed. Going to the next one, IPC guidelines. Of course, when you have guidelines, it must be based on evidence. So an IPC guideline will provide clear evidence-based standards of practice that will guide everyone within that facility to practice according to standards. And it also provides a means to hold healthcare workers accountable because the standards have been set. The guidelines are there, the SOPs are there, the policies are there. This is how you should do it. So any healthcare worker that doesn't follow the guidelines will be held accountable. And fidelity to IPC guidelines will definitely lead to desired outcomes. If in our facility, for instance, we are pushing for compliance with the 5 moments for hand hygiene, and it's clearly stated, and healthcare workers know that before I touch a patient, I should perform hand hygiene. Before I get into a sterile, before I do an aseptic procedure, I should perform hand hygiene. After I'm exposed to blood and body fluid, I should perform hand hygiene, and so forth. So if everyone knows this and follows it, you will not discover that we'll be achieving the desired outcome of breaking the chain of transmission in the healthcare facility. Talk about education and training. Of course, education and training will empower the healthcare workers with the current knowledge and skills they need to practice IPC. In one of my presentations, I made this remark that a knowledgeable and skilled health workforce is indeed an asset of quality improvement. Because while you are educating and training your workers, you don't just talk about, you don't just come and be telling them about infections, their names, and all those things. You also want to teach them.
It outside, though.
You also want to teach them on quality improvement. You want to teach them on the science of patient safety. You want to teach them leadership. You want to teach them administration. You want to teach them how to collect and manage data. So all this will come under that package. So you empower the staff, the frontline staff. Those are the sharp end. So they both have the knowledge and they have the skill to implement IPC interventions or strategies. Then, of course, health surveillance for healthcare associated infection. That's the crux of the matter. Because when we implement surveillance, we are actually, looking for a way to identify trends, to know what is happening, whether whatever measures we are putting in place to control HIs is working or not. It's a way to force us to begin to look at what we are doing, to scrutinize our efforts. And the result from our surveillance for HI can also serve as an indicator for quality of care in the hospital. So HI surveillance is very, very important. Unfortunately, we have not shown, a high fidelity to HI surveillance. I really appreciate what happened a couple of months ago, where the NCDC did a great job by running a pilot surveillance of HI. I learned that there are plans to scale it up to cover all the Orange Network facility. But you observe that for those of us who participated, after that initial push, no one seemed to talk about it again in our facilities, even after we presented our results to those who needed to know. So HI surveillance is very, very important. It will keep everyone on their toes to know that we're actually monitoring and tracking this thing. Are we making progress? How do we know we are making progress? Then you now talk about the multimodal strategies, which is a powerful tool for bringing about behavior change. Now, this multimodal strategy, I think the emphasis there is that you don't just use one approach to achieve the objective. You want to use multiple strategy, implemented in an integrated fashion so that it can achieve better results. Of course, studies have shown that single strategies don't achieve sustained behavior change. So for us to achieve behavior change when it comes to IPC, or for us to achieve a kind of a core of IPC, then we need to apply the multimodal strategies. Commonly, we talk about the system change, that is having the necessary infrastructure to support IPC practice or quality improvement. Then you talk about teaching it as the education and training, selling it, more like I say, market it, promote it, communicate, communicate. Let everyone know what you are doing. I mean, all the workers, create a conducive environment for them to practice IPC. Make the alcohol-based hand sanitizer available. Make the gloves available. Ensure that you have your sterilization equipment working. All those things should be in place. Then check it, which is like measurement. Continue to measure, continue to monitor, and audit and provide feedback. It's all part of the multimodal strategy. Then, of course, leave it, which is talking about the culture. Leave it, let it become a lifestyle. Let it become the way we do things in our facility. So the multimodal strategy, in fact, is the backbone of IPC. And I know that multimodal strategy will also be used to address other quality issues in healthcare. Then the next, monitoring and feedback, which is also another aspect of core components. Like I said before, measurement is key. You can't improve what you can't measure, or you can't improve what you don't measure. How do you know if you are even succeeding? I mean, all the measures. I keep saying, how do I even know that all these noise we make about hand hygiene is working when we don't do if we are improving or improving? So we need to apply this other strategy of constantly looking at what we are doing, assessing if we are meeting the standards set in our guidelines. If the goals we have set for improvement, we are achieving them, we need to monitor. These are all strategies to ensure continuous quality improvement. Remember, we are talking about targeting or reducing healthcare-associated infections. Then workload, staffing, and bed occupancy. Workload, staffing, and bed occupancy is another very, very important one. We know that if we are understaffed, there's a likelihood that healthcare workers will not adhere to IPC practices. I've seen that a lot, where you have maybe 2 nurses providing care for like 30 patients within a shift. Of course, they will not comply with hand hygiene. They will quickly move from one patient to the other, with their gloves on, and then they'll be transmitting infection as they go. So if this is addressed, it's definitely going to improve the quality of care. Overcrowding of our wards, high bed occupancy rates can also promote the spread of infection within the healthcare facility. In fact, I read an article that suggests that if you have more than 85% bed occupancy, then there's a likelihood that transmission of infection will be taking place in that particular ward. And sometimes when there's overcrowding, some patients are forced to leave the hospital early, even when they are not ready to go home. And then when they go home, they will not develop an HI. Of course, you know that the definition of HI also covers a period of 30 days after discharge from the hospital. If you develop any infection, it's still part of healthcare-associated infection. Then looking at the built environment, which is I would say is the cornerstone of IPC. The built environment, the materials, and the equipment for IPC. If they are not there, it's practically impossible to practice IPC. Without adequate water, sanitation and hygiene equipment, or materials within the workplace, you cannot practice IPC. So I'll add here that with the last statement there, that implementing and sustaining the IPC components can significantly help to improve the overall quality of healthcare delivery in any setting. So looking at the core component of IPC, one can see how, if they are implemented in our facilities, they are going to cause a major shift in the way quality is perceived in our health system. So in conclusion, IPC is a critical aspect of quality improvement in healthcare setting, just like we have seen in the previous slides. And IPC plays a vital role in patient safety, because patient harm is one of the aspects of quality that must be addressed. Because when a patient comes to the hospital, he or she is expecting to get help and not to be harmed. IPC also prevents adverse events. Adverse events beyond the healthcare-associated infection. Patients stay longer in the hospital. They pay more money. I have observed patients who developed serious infection while in the hospital. And we know that they got this infection by maybe we're not doing something right, but they end up paying for it because, of course, we pay for healthcare services out of pocket in our country. Most of our healthcare financing is out of pocket payment. So they will pay for it, will spend their money, and some of them die from these conditions. So these are adverse events that, if we implement good IPC measures, will actually prevent this adverse event. And of course, compliance with standard and regulation. We talked about the guidelines. Once we have our guidelines, which are evidence-based, and we comply with them, then we are sure of ensuring high quality care. I'm so happy that the NCDC is pushing hard for us to have an IPC legal framework in the country. And I'm sure when that will come into force, it will not be business as usual for healthcare workers, because there will be a consequence for not complying with IPC standards while we are providing healthcare. And IPC will also help to strengthen our healthcare delivery systems. Like I said, if you look at the core components, you take a look at them again, you will see that all the components working together would actually strengthen our healthcare delivery, from having teams who are knowledgeable, having a very robust built environment, equipment all working. Then we will definitely strengthen the way we provide care to our patients. Not just that. Okay, this one is not in this slide. I think I added it last. It's a strong IPC culture. It's a catalyst for quality improvement in resource constrained settings like ours. I really believe that if we can create the IPC culture whereby it will be acceptable to do it right all the time. For instance, there is no penalty for non-compliance with hand hygiene. Whereas in some climes, if you violate their hand hygiene policy, you'll be punished. So yeah, we don't really have that culture of IPC. It's business as culture. People will not be so scared. They will just know that this is the way we do it here. We are safe. And they'll be confident that their patients are also safe in their care. I want to believe that based on what we have presented in the last few minutes, we can comfortably say that IPC indeed has a critical role to play in quality improvement in healthcare settings in our country and across the globe. Thank you for your attention. So I'll take your comments and your questions and other feedbacks. Thank you, and over.
Thank you very much, Dr. Godswill Ogbonnaya. That was a wonderful presentation, despite all the hitches we had with the internet at the beginning. Please, can we give him a resounding round of applause? For today was improving healthcare quality, the role of infection prevention and control. So Dr. Ogbonnaya has shown us how infection prevention and control is central to any healthcare quality improvement process. In summary, you cannot have quality healthcare delivery without infection prevention and control. So thank you so much, Dr. Godswill Ogbonnaya and Mrs. Mbang, and who shared with us practical experiences on how in her facility, a primary healthcare center, 12-bedded facility, she was able to bring in innovations despite minimal resources to improve the quality of healthcare delivery. So the little at her disposal has been able to do a lot. So do we have questions and comments for our presenters? And while that is ongoing, please, I would kindly ask you to fill in the feedback to help us improve on our sessions. Let me see what we have in the chat box. Okay, somebody says, how do you design education and training for infection prevention and control? That's a very broad question. Dr. Ogbonnaya, do you want to take that? Okay, someone has even commented, Tony has commented that there's a standard national and WHO training curriculum. training for infection prevention and control is usually targeted. That's why I said it's a very broad question. We have many aspects of infection prevention and control. So you have to know which aspects do you want to address. And when you're also talking about training, you know, most times you're dealing with adults. So there are particular strategies that you need to implement when it comes to planning training programs for adults. You don't train adults the way you train youngsters. And when it comes to infection prevention and control, your aim and your emphasis is to achieve behavioral change. So all those strategies that are involved with adult education have to be brought in. Various ways of conveying information and ensuring that the intended information is absorbed by the participants. So it's very broad when it comes to training for IPC, which is why usually have training of trainers when it comes to something as critical as infection prevention and control. So you can say why I said it's a very broad question. Then we have another comment here which says HAI surveillance may not be applicable in some facilities due to poor functioning of non-functional laboratories. Dr. Ogbonnaya, do you want to address that?
Yes, I would say that HI surveillance can actually take place in all healthcare facilities. Remember, it's not just about patients who are on admission. You also have HIs in ambulatory settings, patients who just visit on outpatient basis. So it's not just about big facilities. You know, you can actually mount HI surveillance in basically all kinds of facilities, including primary healthcare settings. But the truth is that, just like the person who posed the question mentioned, we may not have the capacity to diagnose or detect HI when they occur in some of these settings. But that doesn't mean that you cannot mount surveillance for HI in such settings.
Yes, in addition to what Dr. Ogbonnaya has said, where there's deficiency in laboratory support, clinical syndromes can be used to categorize HAIs, which can now be used in surveillance. So one will not just say, because I do not have a standard microbiology lab, then I'll not conduct HAIs. You can use clinical syndromes, that is depending on the signs and the symptoms patients present with and the signs that the physicians elicit. You can use that to develop your surveillance system and then conduct HAI surveillance. Please, a reminder to fill in the feedback links. Then yes, comment, very well done, Dr. Ogbonnaya. Okay, there's some comments about getting the slides. So for you to receive the recorded session, you have to complete the NSIC membership form. After doing that, you usually have access to all presentations. Once you attend the sessions, they will now be sent to your email. So I would like to make some comments on, do we have other questions? Is anybody's hand up? Okay, yes, I have two hands up here.
Yeah, 2 hands are up.
I have 2 hands up here. I can see Tony, Ediga, and Mbang. And
Mine
Mbang,
is
is
down.
your hand
You've
down?
answered the question, ma. The question on the laboratory, yes, that was my question.
Okay, all right. So Tony, Ediga, can we hear your comment or question?
Okay. Thank you, everyone, and thank you, Chief Ogbonnaya, for the wonderful presentation. I just want to make the little comment I want to just make is that just like we were discussing earlier regarding the facility experience from Calabar, the way IPC is going now, we really advocating that. I don't know on this call if there are some policymakers and and government officials and people that are involved in design of our healthcare facilities and all of that, they need to really, we're going to try to be pushing towards that part where if you look at the 8 core components, you are seeing built environment coming the least, but it's most kind of, all of them are important, but it's very key. At the time of design of hospitals, how you can put things in place that really improve quality of care and also reduce healthcare associated infections. But a lot of time facilities are built without the input of, IPC professionals and all of that. So we are now advocating that when hospitals are being designed from scratch before they are even built, someone who have the lens of IPC will also advise on what and things to do to make, for instance, the facility where the experience was shared, they continue to use improvised means of getting hand wash and all of that. If at the beginning they had it thought in mind for IPC, there will be a provision for wash hand stations across some points where it's needed. So it's key that this should be taken into consideration. Concerning HI surveillance, even though I agree that microbiology lab might not be necessary, we can use clinical syndrome, but we also do HI surveillance also to help to prevent antimicrobial resistance and all of that. So beyond just doing the surveillance, you also need to be certain on the laboratory services that can point to what resistance pattern we have in a particular facility, so we can be able to target our intervention to help to reduce this HI in our facility. Thank you, and over.
Thank you very much, Tony. Dr. Ogbonnaya, you want to have any comments for him? You want
I
to
think
make
his
any
comment,
response?
yes. I think what you said is very, very apt. While we have said that you can mount surveillance in almost any setting where healthcare is being delivered, there is also the need for a strong laboratory support. Because it's not just to say, oh, there's an infection. You want to know how important that infection is. Vis-a-vis preventing the spread to other patients and staff and other individuals who come to the facility. So that is why there is also a need for that strong laboratory support. In fact, in our own program, in the Orange Network, HI surveillance has been restricted to the tertiary institutions, for now, until we have such capacity where we can now link up the other levels of care to maybe laboratories that will conduct the diagnosis. I don't know what is up in the sleeves, but I'm sure that there's something coming up. We call it HI next. Maybe when that is unveiled, we'll understand what it's like. But I think it's huge. NCDC is making some really giant strides to ensure that the issue of HI is addressed in our country, and we are looking forward to that, hoping that by God's grace, a time will come when it will not just be an issue of the tertiary hospitals, both the general hospitals, that is secondary facilities, and primary healthcare facilities will all be involved in surveillance and prevention of HIs. Thank you, and over.
Thank you, Tony, for those comments. In addition to what Dr. Ogbonnaya has said, I think I just want to reiterate that, just like we saw from Mrs. Mbang's presentation, if you insist that you must have everything you need before you start implementing infection prevention and control programs or the core components of IPC, then you hardly get anything done. But if you are in a facility where for now a standardized microbiology lab is a challenge, you can start where you are with clinical syndromes. So starting where you are, by the time you can present your data to the hospital, and they now realize that, okay, even without laboratory support, you're able to do this, then your management will be more inclined towards supporting whatever it is you need to improve the efforts on HI surveillance. Because being an IPC professional, you try to get the system to see where it can improve the facility and its services based on the little support that you have given as a professional. You know how the Nigerian health system works, and medical directors really don't want to spend money, even though we have seen from Dr. Ogbonnaya's presentation that you will save billions of dollars in HAIs by implementing the core components of infection prevention and control. Sometimes to get them to buy into what you are saying, you have to make do with what you have available. So thank you very much. Any more comments? I don't think we have any more comments in the chat box. So please, I would like to ask everyone to fill the feedback so that we can improve our sessions. We also appreciate all those who made time out to be with us, and we really appreciate our host, iEcho India. He did a great job of helping us to share the slides and sending reminders for this meeting. So I was informed earlier that we have some people joining us from other countries. Would you like to say something? I can't identify who they are, if they are still here. Would you like to say something if they are still here? From the West African ICANN Hub.
Dr. Adeni, did they join? Because we don't know them. Dr. Adeni Yoshike, are you on?
Okay, maybe they did not join this session.
Maybe they did not.
Okay. So Tony, is this a new hand or an old hand? Tony, is this a new hand or an old hand?
It's an old one, sorry.
All right, all right, all right. So, Ma, do you have any comments? Round up.
Well, I just want to thank our facilitators for giving us, making it a day. And I noticed that a lot of the CCAS facilitators are here. I want to say thank you. I've seen Dr. Adewakun. I've seen Nini Yola Williams. I don't know, but I know Mrs. Omishore has been on. I just want to thank everybody for making time out to be on this very, very, very important session. Very interesting, very deep. A journey of 1,000 miles starts with a step. And if we all, maybe few, we should think big. We should think about think about NCDC getting that legislation. Is this group that will be the champion to spread the word? And I just want to appeal to us that we should continue to spread the word. We should continue to do what we know how to do best. We should think big, but we need to start small. That Mrs. Mbang told us. Don't say it's a PAC. It's a very small place. But we need to start small so that we can, but we need to do something now. We shouldn't just wait and say, oh, I'll wait until everything is ready. Which I think is very, very important as well. But we should believe in ourselves. We would have challenges, definitely. The quality, if we all think quality, definitely we will improve IPC. And if IPC is brought, everything together, we will eventually make it. And I just want to wish all of us a very, very pleasant evening. And for those of us that are members of NSIC, if you are already a member, kindly get in touch with I will introduce the new admin officer because I noticed that we have about 40-something. It's dropping now to 35 people on the call. If you haven't paid your membership dues, please pay up. It's still 10,000 per year, but we are thinking because it's combining the ICAN, which is African Infection Control Network, and NSIC for a start until we review because of the exchange rate. So take the opportunity to make sure you pay that 10,000 before the price go up, so that you can have access to so many things that we have packaged for you. And I want to say thank you again to our facilitators. You've made our day. Until next month on
Thank you.
25th of July, where we hope to come up with another very interesting topic. We'll want to say good evening, good afternoon, and good evening. Thank you all very much. God bless you all.
Thank you.
Thank you. Bye.
Thank
Bye.
you. Bye-bye.
Thank you.
Bye.
Please don't forget to fill the feedback form.
Madam Ekaite,